And welcome back. I'm Mabel, Jong. You're watching continuing coverage of the World Healthcare Congress coming to you from Washington, D.C. A very, very warm welcome to all of you folks that have joined us virtually. And in our studio this morning, Dr. Imelda Dacones, President and CEO of Northwest Permanente, has come in to check in. Thank you, Dr. Dacones, for your time.
Thank you.
You have a opioid prescription reduction initiative going on at Kaiser Permanente. Could you tell me the genesis of that program? When did it start? And what really is the mission of it?
So for some of our viewers who may not be familiar with Kaiser Permanente, KP is an organization that's comprised of really three distinct entities. There's Kaiser Foundation Health Plan, there's Kaiser Foundation Hospitals, and then there's the Permanente portion, which is the medical group. And what the viewers might not know is that the Permanente medical groups in each of the states where we operate are distinct, separate, independent physician-led corporations and organizations, and we contract with Kaiser. So it's a unique integrated system in that way, and the reason I'm going into a little bit about how we're organized is I believe that that fuels a lot of how we do it that makes a difference in terms of outcomes. So in the opioid crisis, this has been a decade-long journey for us in KP in the sense that the physicians, the medical groups, got together, the leaders, and said, we have to do something about this. And so this whole thing was a physician-led in the very beginning and throughout the process and journey. And then we have stakeholder pharmacy operation leadership, where we then got together and are the architects of what will it take, what does it take, building on what we know from the literature, and also a lot of it is us making it up as we went and iterating over the journey. So over the years, I want to say that it wasn't one thing. When we started this in KP Northwest in 2009, we started with multidisciplinary physician leaders in the fields of addiction medicine, psychiatry, physical medicine with physiatry, primary care, specialty care, and then again, folding in our pharmacists into that. And then it was, what is that program that's going to help? And it's beyond education. It's really, what are the systems and tools we need to put in place to make the right thing and doing the right thing easier? So you go to the EMR as one integrated medical group from primary care to specialty care. We have that advantage. We are one medical group, we're connected by one EMR, so our physicians go into the EMR and program. By department, what are those prescription guidelines? What are those limits in the number of pills or tablets you're going to prescribe as a general surgeon for specific cases? So, you know, if you open up the medical record and you ordered something, instead of getting 10 options, you might just get 3. So then you begin to narrow the choices and make it easier to do the right thing, particularly in a busy practice, right? And as I shared this morning, we bucketed the work in the prevention arm as well as in the treatment arm. And the prevention arm for all the work that we've done is really about how do we reduce the number of pills prescribed at the first fill after a surgery or after any encounter with their system. And in the treatment arm, how do we help our patients with chronic pain begin to wean the dosage, right? So on the treatment arm, over the 8 years, from 2009 to 2017, we've reduced for our patients with chronic pain the average daily morphine milligram equivalent dose from was 96.8 milligrams in 2009. End of 2017, it's down to 41.7 milligrams, right? So that's a nearly 60% reduction. So that's an example. In the prevention arm, when our surgeons in our surgical departments, of which there are many, when they have a patient who has surgery and they are what we say narcotic naive, we limit the number of pills of opiates that they're prescribed. And then we track by clinician, by department, if they give out refills within 45 days after surgery. And we have a feedback and monitoring system, so we work with the individual surgeon, for example, if we start seeing a trend of prescriptions over the 45-day period that we look at. And lastly, we have an interesting structure in KP Northwest because we have a dental program. We are the only region in KP that has a dental program within it. So our Permanente dentists work with us physicians and clinicians, and together, because we're integrated in the same EMR, we can follow our patients within, when they toggle between the two worlds of dentists and the medical world. So these are just some ways by how our structure, how we're leveraging IT and all the other support staff, pharmacists, physical therapists, behaviorists, to help put this program together. And we're still building, and we're still enhancing it as we learn and go.
And it seems like that's very important since we are still right in the middle of this crisis, which seems to be building in momentum.
Yeah.
You took us back to 2009. What was the mindset of the healthcare sector then when the dosage of the medicine was so high?
Yeah, I would say it's a spectrum, because when you don't have data and not everybody has the EMR connecting every specialty with primary care, right? In the fee-for-service world or in the outside world of KP, we have separate groups taking care of the same patient, and they're not on the same EMR, so they don't have the data. So you're kind of flying blind, so to speak. So if you get a prescription from your surgeon after surgery, and your primary care doctor who's unconnected also gives you a prescription, you can begin to appreciate how you might collect, for example, the amounts that you do. And we also know in Oregon that we have patients who go from one emergency room to another to accumulate these prescriptions. So from the standpoint of within KP, it was really, we have the data. I mean, look at the numbers of how many of our patients are on such high dosages and the number of pills per refill we were giving out. So it was really a call to action within our group, and what I call self-inflicted.
Okay.
It's self-inflicted in terms of limiting ourselves into what and how much we can prescribe, but of course engaging the physicians and clinicians with it.
You've reduced the strength of the medicine quite dramatically, as you mentioned.
Yes.
How much further can it go, and what does KP think you can get it down to, or what is the goal?
Yeah, this is one of those where it's a race to the bottom, as I say. The lower part of that will be dictated by our patients in terms of a shared decision-making conversation. That's both for our patients on chronic therapy, right? Because we work with them, we partner with them, and how much lower can you get down on the average daily dosage? And then for the new prescriptions for the opiate naive patients, if you have gallbladder surgery, what's the right amount of narcotic pain pills that makes sense for you? Is it 5? Is it 10? Is it 15? So that's where that we're still learning in that, but it is a race to the bottom. What's the lowest, what's the minimum that can get you by? Plus, deploying other tactics and levers to help you, say Motrin and Tylenol, that with narcotic pain pill. What are the other modalities of non-pharmacologic interventions? And I mentioned during the conversation acupuncture, massage, many other different non-pharmacologic ways we can help our patients manage pain. And the last thing I'm going to say is in anesthesia, the techniques and also having a multimodal pain management approach with our anesthesiologists helps tremendously, because we know with that we reduce the amount of opiates you get during surgery, and that sets you up for requiring and needing less in the post-op and perioperative period when that happens.
Well, how do you run this program in concert with other efforts by KP to reduce readmissions and try to get patients out the door faster? I mean, one technique might be to send them home with more medication so they can manage themselves. So, if you're trying to run one program on this side and then you've got your program on the other side, are you talking to one another?
Well, we're one system in KP, so, well, the beauty of it is, let's talk about early recovery after surgery. The three legs on which early recovery after surgery stand are less opioids, early ambulation, so making sure the patient gets up and walks right after surgery or soon after, and allowing the patient to eat sooner rather than later. So because of that, patients their length of stay in the hospital is shorter. Because of that, their post-operative complications like constipation and where your bowel is taking longer to wake up from anesthesia because you've got now opiates on board, all those things are improved. So this work actually touches other systems and works in our organization in that it's the whole picture and outcome for the patient is better. So you're addressing the opioid crisis here and dosage and preventing people, but while you're doing that, it's benefiting in terms of length of stay for the patients who have surgery. It's benefiting in that it's reduced complications from that and reduced readmission from complications of narcotics. So it's a virtuous cycle.
Okay, Dr. Dacones, we're going to have to leave it there, but thank you so much
No,
for stopping by.
Thank you.
And I'm Mabel. Jong. Thank you for watching. Stay with us.